Hello. Hope everyone's doing well. I hope we're past our post-lunch slumber. I hope the caffeine's kicked in. If you need the Nanaimo bar, go get some to make it to the next, hopefully half an hour. It's always hard to go last. I don't know if you guys have ever had to place yourself in a talent show, but nobody picks last. But here we are. So again, my name's Sebastian. Pleasure to be here. I think most of you know Nour and of course Dr. Warkentin. I'm a new face, so excited to meet everybody here. And as an introduction, I'm going to be very provocative and basically imply that TISS is not doing its job. So how's that? So our presentation is called TISS with extra T's and S's. Thrombocyte transfusion thrombosis injury isn't systematically surveyed. And so we're presenting a case where there's a transfusion of a platelet unit and a patient who underwent cardiac surgery where it may have been plausibly linked to injury, which we'll get into a bit more. So I will get started by passing it over to Nour. She'll just start the first part.
Thanks, Seb. Thanks, everyone. So I'm not gonna go through what does TTISS do or what's the history or background of it, because Joanne this morning gave us a great talk about it. So I'm gonna skip that. But I would like to say quickly that Joanne, Nancy, Baimee, and Melanie, and the whole TTISS team are a great support for us. I feel very lucky as a TSO to have their support. They help me a lot doing my job. Like, they don't even wait for me to ask or reach out. They always check on me and give me all the resources and guidance. So thank you so much. In Hamilton back in May 2022, we transitioned into Epic. And I listened to Christine talk this morning that UHN also suffered a little bit during the transition, and we were missing a lot of reactions and reporting reaction, tracking them. So we created a temporary process. So this is what we currently do, but we also created a team of people with stakeholders to create a better process. It should go live soon, before the end of the year, but this is what we currently do. So basically, when the nurse or the attending physician suspect or observe a transfusion reaction, they document the vital signs, the symptoms, the measures taken, everything in Epic, and then they should call the transfusion medicine department and report the call by phone. This is our only notification we receive. And then the MLT who receives the call, she will send an email to the TSO, which is me, and then she will say, oh, we had this patient, he received this unit, and the time, and then it's my job to log into Epic, review the case, and then enter all the symptoms and the reaction, the conclusion into the REDCap system. And then I also report all the transfusion reaction to the Transfusion Medicine Committee annually. Here is the data for the 5 sites in Hamilton from the last 4 years. And you can see the majority of the reaction we report are categorized under grade 1 non-severe. You can see here, this is what we have to select from the type of the adverse reaction on the REDCap. I took this screenshot from the REDCap website, and you can see all the different kinds of transfusion reactions here, like ranging from febrile, allergic, taco, trolley, all these things. Also, we have other results of investigations and unknown, but you can see here thrombosis is not listed. This slide here, I worked with Seb and Dr. Warkentin, and we had some challenges in categorizing these types of reactions or the transfusion reactions conclusion and to 3 categories. So we thought some of them might cross-link into and injuries and non-injurious and non-injurious, but we thought, okay, non-injurious is febrile, non-hemolytic reaction, minor allergic reaction, delayed serologic reaction. often injurious, but can also cross-linked into non-injurious. TACO, acute and delayed transfusion reaction, aseptic meningitis, viral infection, bacterial infection, anaphylactic shock, TRALI, and hyperhemolysis. And for sure, the injurious is transfusion-associated graft versus host disease. But again, we can tell from this slide that most of them, or the reaction we see is where or are non-injurious, and they can also, depending on the whole context, you can also move them back and forth and categorize them. So again, many of these reactions result in non-injury. And then we have also another data from national data actually across Canada. We got it from the government of Canada from 2016 to 2020. 68.8% were non-severe, and then 25.2% severe, and only 5% life-threatening or death. So the question is, are there adverse events that we aren't tracking? And our thesis is that there are, and one of them is the platelet transfusion that might cause thrombosis. And now I'm going to turn it into Seb. He will discuss the case.
Okay, so what a beautiful image of a platelet right in the raw. So these platelets, potential arbiters of pathology, they cause thrombotic events, especially within the arterial system. These disc-shaped anucleate cells, they play a vital role in primary hemostasis, but like everything else in the body, it relies on physiologic balance. When this balance is disrupted, for example, in those at risk of stroke or MI, we use antiplatelet agents as a mainstay of treatment. And so logically, platelets can plausibly contribute to thrombosis, and they are a known concern in HIT and TTP. So in that regard, we present a case where such balance is upset that plausibly links a platelet transfusion to thrombosis. So our case, this was a 37-year-old male who underwent aortic valve repair and replacement of an ascending aorta. This was around about a year and a half ago in April of 2022. He had a bicuspid aortic valve, and then that led to severe aortic insufficiency. And then as a result of that, his left ventricle was dilated. And part of that disease process, you also get aneurysm of your ascending aorta. This gentleman also had Crohn's disease, and he had an ileal resection at age 12. His medications, he was on azathioprine and infliximab for his Crohn's. It's a bit of a busy slide, but this is just his pre-op status. He was of normal, maybe lighter weight, 57 kilos, normal height. His pre-op vitals were essentially normal. I just wanted to highlight of note that his hemoglobin, platelets, and MCV were normal, except that this patient's INR was slightly elevated at 1.3, which we'll come back to later. But we can see there's no significantly active biochemical disease for his Crohn's. This is also another busy slide, but I'll just let you know, as sort of an anesthesiologist, in terms of the intraoperative course, everything here essentially is normal by 12:09. So case starts, a patient for the surgery would get TXA, heparin, lots of heparin. They would start bypass, apply a cross clamp, give protamine to reverse the heparin, remove the cross clamp, stop the bypass. Now, like I said, by 12:09, everything was unremarkable. And at 12:42, they do what's called a platelet works, which is a point of care platelet assay, functional platelet testing right there in the operating room. And it gives you results very quickly, within 10-20 minutes. I'll go through that a little bit more afterwards. But from the results of the platelet works, they decide to administer 1 unit of platelets. And then further on, they give additional protamine. And at 13:32, the patient was transferred to the ICU. His labs before the bypass, and this is just to show that his hemoglobin and platelets decreased slightly, but not unexpected as a result of intraoperative hemodilution and some surgical blood loss. This was the result of his platelet works. So this is what we use at our institution. It shows that his total platelets were 131 and his non-functioning platelets were 79. And then by subtraction, we infer that the functioning platelets is 52. And then I'll just note the box on the bottom here, which says functioning platelets less than 75, consider transfusion if patient bleeding. And this is interesting because it's not clear to us where that recommendation came from, who wrote that, who printed that on the reporting record, which is widely used at our hospital. Oh, this is supposed to be interactive, so have your phones ready and your buzzers. So does your institution use point of care platelet function / hemostasis testing, e.g. Platelet Works, ROTEM, or TAG? Just curious. No. Interesting. Yeah, I didn't know what to expect from this, but I guess the majority used with an increasing trend of adverse events with an increasing number of units given. So if you look through the columns, units of platelet transfused 0, 5, 10, greater than 10. And if you look at the stroke part, you can see actually a clear relationship between stroke and platelet dosing with an increasing trend with increased units. But this is before propensity matching. So people can say, well, if you had a platelet transfusion, you were sicker to begin with. So if we look at the table below, after they did propensity matching, we see that this association goes away. It showed that transfusion of platelets was not independently associated with a statistically significant increased risk of morbidity and mortality, including stroke. Interesting. So their conclusion, transfusion of liquid-reduced platelets was not independently associated with morbidity or mortality when effects of confounders were adjusted by logistic regression or propensity score analyses. And this is just a second study, European 2015 multi-center Denmark hospitals over 6 years, almost 7,000 patients undergoing CABG and CABG AVR. And in this group, their ASA and clopidogrel was held 5 days before OR, and they looked at 30-day mortality, MI, and stroke. And their indications for platelet transfusions varied, but usually it was less than 100 plus bleeding after bypass, or if you had prolonged bypass with signs of microvascular bleeding, irrespective of counts. TXA and apertin was given to majority of patients, and then they determined their post-platelet count upon arrival to the ICU. They did not use platelet function tests. And just like the Canadian study, this study also showed an increased risk of stroke with platelet transfusion. But also like the Canadian study, when they adjusted for red blood cell transfusion, plasma transfusion, renal failure, inotropic treatment, they did not find a statistically significant difference between platelet transfusion and their outcome of post-op mortality, stroke, MI, and the need for repeat coronary vascularization. So they also used propensity matching as well. So when they adjust for these confounders, no increased risk of stroke. We had to ask ourselves, like, do these studies apply to our patient? Our patient was a particularly, I think, different phenotype compared to the patients that would undergo cardiac surgery for a bypass. Our patient was young, he was 35. He had no coronary artery disease, no comorbidities apart from Crohn's and his cardiac disease. And he did very well post-op. He was extubated the same day. He was not in kidney failure, not on pressors, and he was not on antiplatelet agents. So a lot of these patients, when they undergo bypass surgery, they continue their ASA throughout surgery. And if you look at these studies, there's heterogeneity in transfusion thresholds. There's variations on how people do platelet testing. And just a brief note about propensities matching, and I think it kind of ties into how this patient was different than what you would see typically in these studies, is that a lot of times with propensity matching, if you're an outlier, depending on how the method, the study is done and how propensity matching and weighting is done, the outliers may not be matched at all. And so, our argument, our suggestion is perhaps, if this patient was part of that study, they may not have been included at all because he would have looked far different than the other participants. Okay, this is another repeat question because I just like to see the tides of movement of opinion. In your opinion, how would you judge the relationship between the platelet transfusion and the subsequent stroke? Now that you've seen some of the literature on this topic, yeah, we're just curious to see if this will change your view. Oh, I like doubtful. That's great. Okay, excellent. So just some concluding thoughts. We're presenting a case. Well, bring it back to Dr. Sturdy's slide, association does not equal causation. But we think that it is a plausible case of thrombosis in this case. There's little evidence for platelet prophylaxis after bypass and CV surgery. So there's a lot of things that we do and we don't know why we do them. And maybe they affect the outcomes of these patients. And then these outcomes are not tracked by TTISS. Now, I understand, just having been here very briefly in this transfusion world with all of you, I understand that reporting can be very challenging. It's incumbent on the nurse or incumbent on the physician. There's a very protocolized process, and in a process that's very protocolized, when you have to go outside of protocol, it's difficult to initiate something, right? So if after the fact, whether it's 1 week after or 1 month after or 6 months after, somebody says, oh, maybe it was a platelet transfusion. I don't know that most people think, oh, we should report that and call TM lab. So I think there's some inherent issues here, which I don't have the answers for, but I think it's more just to present a case so that there's awareness for everybody. And also just to highlight the fact that based on the literature review that we did, there's no increased risk of thrombosis with platelet transfusions and CV surgery based on observational studies for propensity matching. And those are references. So we welcome any questions, criticisms, doubtfulness at all. Dr. Warkentin, my backup is coming. Yes.
Figured since I'm on the program as one of the presenters, I should say something, right? So to me, this is a pretty interesting case. So the reason why this case is being presented is, first of all, it was not presented to the transfusion service as a transfusion reaction. And it is 1.5 years after it occurred. So the reason why we're even talking about it is because I was a kind of an Uber consult, if you know what I mean. The thrombosis service was already involved in the case, trying to manage the clot and what's going on. And the thrombosis doctor thought it's a pretty odd case, so kind of asked me for like a second consult just to review this case. And I have to say, and of course, being a HIT researcher, the first thing I did was rule out HIT, and that's an interesting story because you can use samples that aren't thrown out. I do that a lot. So no one thought of HIT at the time, and I was seeing the patient a week later. But because antiphospholipid testing was done, you saw on post-op day 2, that means the samples are still in the lab, because in our hospital, we keep blood samples for 6 weeks in the special coag lab if they've been investigated. So that's a cool little trick, because you could then show there were no HIT antibodies in that sample. So that was kind of interesting. And then while we're at it, we found this factor 5 story, which is sort of interesting. Why was his INR high? So he's got factor 5, which I don't think is playing a role, but it's an odd finding. You don't see moderate factor 5 deficiency. But I have to say, when I did this consult, what struck me about the case was that he's a young fellow with really no comorbidities. I mean, yeah, he had inflammatory bowel disease, but his MCV was perfect. He was on one of these disease-suppressing drugs. The disease was not active. So he's really about as well a patient as you can have going into heart surgery. And it also struck me that how often do you see a platelet increment with a number of, 315 or whatever it was after the platelet trend? It's a very high platelet count. And a lot of clinicians aren't aware that when you have heart surgery, your von Willebrand levels rise dramatically. And so what that means is normally when you have surgery, you're hemodiluted to a platelet count that's low, 100, 120, 80. And so if your von Willebrand level's high, well, at least your platelet count is low. But here's an artificial situation where platelets were transfused, you have a high increment, you probably have, we didn't have a blood sample, unfortunately, right at that time. I would have done it if I'd been consulted right at the time of the stroke, but he probably had a very high von Willebrand level. So those are the circumstances for platelet von Willebrand interaction. So I must say, my impression, so you're asked to do a consult. Why do you think this patient had a stroke? And deep down, I think it was because of the platelet transfusion. And so, then I forget about it. We don't normally report those. I didn't tell the transfusion lab, even though I'm the transfusion director. But when Seb, said, hey, I want to present a case at these rounds, I remembered this case. And I thought, wow. And we can do extra work. We can talk to pathology. They never throw out anything. They got, 100-year-old samples in the Hamilton General. Pathologists never throw out anything. So it gave us a chance to look for platelets in the clot. And it's an extremely platelet-rich thrombus. And so I have to say, to me, this is the most convincing case I've ever seen in my 35-year transfusion career of a transfusion that plausibly seems to be associated with thrombosis. And I have to say, full disclosure, I do a lot of medical legal consulting in my free time. And what's interesting about medical legal consulting, and this comes back to what Christine was talking about, level of evidence and probabilities. If you're doing criminal cases, it's got to be very high probability, right? Without a reasonable doubt, whatever that is, 1% or 5%, it's a low number. But medical legal is like civil litigation, and that's where you have a 51% threshold. And when you do a case analysis, yes, you can be informed by trials, you can be informed by all these propensity trials that show, there's no clear association between thrombosis and platelets. That's what the studies seem to show. And yes, that can inform your thinking. But at the end of the day, when you do a case analysis, just like if you're a jury in a trial or a jury in a civil trial or criminal trial, you're just basing it on the evidence of the case, right? Sure, you can be informed by your general knowledge and scientific knowledge and what you read in the literature, but at the end, it comes down to the case. So anyways, I thank Nour and Seb for presenting the case. I thank you for listening to it. Deep down, to me, this is as persuasive a picture, but even I wouldn't vote definite, but I would probably vote probable. To me, this looks like the platelet had something to do with it. Young, lack of comorbidities, very big increment, strong temporal association, and a patient who was talking, was doing well, et cetera. And so it does raise the issue, should we be automatically looking for, should we be screening? Should we have a question? Does someone have a DVT, a stroke, an MI within, say, 24 hours or 12 hours of a blood transfusion or a platelet transfusion? We certainly don't do that. And I'm the last one that wants to create work for our beleaguered technologists. But, this is TTISS. And as Seb and I discussed, the I stands for injury. And unlike a lot of the things we track in transfusion that aren't injurious, the point of one of our slides, thrombotic events do tend to be injurious, particularly when they're in the arterial side of the circulation. And so it's, we presented this case as kind of food for thought for this audience and for this TTISS venue. So appreciate your listening and welcome the comments that you have.